Okay, let's wrap up again with poor trigger. How do we check it? Uh, is patient moving his inspiratory muscle but only getting the backup rate, control breaths only? When you see this, that means the patient having poor trigger. And as you know, flow, there's trigger, either flow trigger or pressure trigger. Weak inspiratory muscle can cause poor trigger whether we are using flow or pressure. And this is can be a problem with very weak, critically ill patients. And the way to solve this problem is lowering threshold. Normally, by default, we pick 3 liter per minute here and 3 centimeter H2O here, that the patient need to suck in air enough to change or to lower the flow in the expiratory muscle, an expiratory limb, by compared to the inspiratory limb of the ventilator by 3 liter per minute. Please see my videos on flow trigger. And here, able to drop the pressure on his chest and then sensed by the ventilator by at least 3 centimeter H2O. So to solve the problem here, we drop the threshold, for example, to 2, and here to 2, make it easier for the patient to reach the threshold. But be careful from dropping it too much, because that will lead to excessive unnecessary triggering, which we'll talk about in next video. So this is how to solve this problem. The other issue with poor flow trigger is the extra flow, as we explained, with continuous nebulizer treatments. And if you have this issue, simply switch the trigger, to pressure trigger, and that will solve the problem. The problem with O2 PEEP, as we explained, it can cause poor pressure trigger, and the way to solve it is treat the underlying, of course, problem. Let's say somebody with COPD, you treat the COPD exacerbation, increase expiratory time to get rid of the O2 PEEP. Please go back to my O2 PEEP videos, and also interestingly increase the PEEP. If you see my previous video, how the relation between PEEP and O2 PEEP, because simply if the O2 PEEP, as I said, if the PEEP, external PEEP at 5, and at the end of our expiration, our alveolar pressure at +5, you need to drop this, let's say, to 2 to trigger the breath. But if this come at 8 and it's still at 5, they still need to be dropped because the ventilator will sense this one. So to get it to 2, we need to drop it by 6. Again, everything will be transmitted, and so instead of the patient requested to drop the pressure by 3, now it's requested by 6. By increasing the PEEP then to, let's say, from 5 to 8, now we'll get rid of this problem, and this is a temporary solution until we fix this problem. It makes all the sense. So this is how we overcome the poor trigger problems. And again, try to investigate to know exactly if lowering the sedation can help with this issue. Also do that, controlling the pain. So you need to optimize patient conditions in general.